This is what a chest CT looks like. So just to orient you, the convention of CT scans is like you're standing at a patient's feet and looking up into the body. And these are slices taken across the body at different levels from top to bottom of the chest in this instance. So in this patient, this is his left side, this is his right side. This thing right here is the sternum, the chest bone. This is his spine. The big black things are his lungs. With a manipulating the data acquired, one can have images like this where you see everything else is whited out, but you can look at the lung parenchyma. And this is an example of what lung metastases look like in someone whose liver I started treating more than 6 years ago. This is actually the top of the liver, because the diaphragm is an arc. So if you cut a straight line across an arc, you get some lung, some liver, some lung again. Ultrasound, inexpensive. There's no radiation. It can be very sensitive for some small tumors, but it's also easy to miss things because it is very operator dependent, and quality varies substantially from institution to institution. And it's impractical for whole body surveillance. I mean, it's good to focus on one area, but you can't see everything from here to here on an ultrasound, and frankly, it doesn't image certain organs very well. Like, you can't see the lungs well with ultrasound. Just ultrasound can be very helpful for biopsying. And if the room were totally dark, because remember, radiologists read in little dark rooms because ambient light is not our friend, but if the room were dark, right there is a tumor. MRI is the most sensitive imaging modality for liver metastases. There's no radiation involved with an MRI. There are no known, and I emphasize known, harmful effects of the MRI. Doesn't cover the whole body. It's better to focus on one area of the body because the scans take a long time to perform. There is substantial variability in the quality of MRIs. To run one of these machines well and use it to its potential involves a lot more physics than I will ever understand. But in that we see MRI scans performed from around the country, we can affirm that there is substantial variability. It's slow, it's noisy, they are affected by motion. This is same patient, same part of the body, with motion and without motion. And you can see how it doesn't take a lot of motion to render the study worthless. This is, again, a slide that Patrick made a couple years ago, but why does an MRI take so long to get? Well, because they do all these different sequences of how they're throwing the magnetic pulses at our bodies to produce these incredibly powerful images. And this is same patient, same level of the body, just going through all the different series that were obtained. And for example, like in this one, all this white stuff is fat. Okay, we all have fat inside our bodies, whether we like it or not. And you can certainly see in other images the fat is suppressed. It doesn't appear the same way. This little white circle here is fluid around the spinal cord, so it's basically water. So on this sequence, watery stuff is bright. On other sequences, watery stuff is dampened. And there are all these different parameters, and people have worked out that an ability to determine, not in all instances, but in many instances, when they see an abnormality, is it apt to be malignant or is it apt to be benign, based on the characteristics of how it appears on all these different sequences. This is jumping back to a CT scan for a moment, but notice the date, August. And I mean, look, this is a good quality CT. Here's the liver, here's the spine, here's the spleen, this is stomach, this is the pancreas. I mean, liver looks pretty good. Patient has scans 2 months later in October. Again, liver looks good. Gorgeous view of the pancreas. This is the vein that drains blood from the spleen. Liver looks good. Okay. Again, we're now in December. Liver looks fine. Hard pressed to say anything's wrong with it. But when you look at an MRI from back in April, just look at all these little white dots in the liver. And all these little white dots there and there are metastases, and you never began to see them on a CT scan. As another example, and unfortunately, this one is projecting too white compared to how I have it on the slide, but this is a good quality CT, different phases of the imaging, and maybe you can start saying, well, maybe there's something funky going on there, but clearly on MRI, you can see that tumor, along with other little white dots in here, and you're really not seeing anything on the CT scan. Another patient, kind of similar story. This is a good quality CT scan, and maybe you get the sense that something's there, but clearly there's a tumor there, tumor. You see them here. These things are actually cysts. It is not uncommon to have benign cysts in the liver. Most of the time, they do nothing. People don't know they have them. They make no difference. So these are just a handful of examples of why we don't feel it's adequate to follow patients with this specific disease with CT scans, and MRI is much preferred. This is what a PET CT looks like. A PET scan is not so much assessing the structure of, seeing tumors as nodules and that sort of thing. It's assessing the metabolic activity, how the tumor is growing and living and that sort of thing. It depends on how much glucose it's using up, okay? And so PET scans can be very helpful, particularly in other diseases, to assess efficacy of treatment, because if the tumor is very obvious at one point, they get a therapy, and then it becomes less obvious, that's evidence that, hey, this stuff is working. It's expensive. Every imaging center doesn't have, a PET scan. It's not sensitive for very small tumors. There's usually a threshold of about 1 centimeter, and tumors under that size will often be missed. A lot of radiation, and takes about 2 hours. So we certainly don't feel it's reasonable to use this for a screening tool. This is a patient with skin melanoma, not eye melanoma, but this is normal brain, normal bladder. It gets excreted by the kidneys, but these are melanoma deposits, and it can be combined with a CT scan to say, oh, we see those little dots, but wow, look how active they are. And it's to help confirm that findings of questionable significance are tumor or not. Okay, so discussing surveillance for a moment. Currently, patients at low risk get MRIs every 6 to 12 months. High-risk patients much more frequently, every 3 months for the first 2 years and 6 months for the next 3 years. This has been our practice for a number of years. There have recently been guidelines issued from the National Comprehensive Cancer Network. Jefferson is not a member. Neither is the University of Penn, neither is the University of Pittsburgh. That may be irrelevant when you're talking in Denver. But this is a consortium of 27 major cancer centers around the country. And they define low-risk patients, Castle Class A, Disomy 3, small primary eye tumors, and say, well, you may want to consider surveillance imaging. Patients with medium risk, Castle Class 1B, bigger-ish tumors of the eye, consider surveillance every 6 to 12 months for 10 years. Okay, which, this is pretty similar to what we've been doing, but just since someone went and issued guidelines very recently, I think these just came out actually in March, it's reasonable to discuss with a group like this. High-risk patients, Castle Class 2, Monosomy 3, bigger primary eye tumors, surveillance every 3 to 6 months for 5 years, and then every 6 to 12 months. So this is a direct quote. At a minimum, all patients should have contrast-enhanced MRI or ultrasound of the liver with a modality preference determined by expertise at the local institution. Additional imaging modalities may include CT scan of the chest, abdomen, or pelvis. However, screening should limit radiation exposure whenever possible. Scans should be performed with IV contrast. Then they also add the zinger of recognizing that there are limited options for systemic recurrence and that regular imaging may cause patient anxiety. I'm quoting this, I didn't write this. Some patients may elect to forego surveillance imaging. We respectfully disagree with that point, but then again, we're not a member of this esteemed group. So we talked a little bit about radiation exposure, which recognize that our radiation exposure as human beings is not zero, okay? We get radiation from the sun. We get radiation from natural sources around us. I mean, where I live, radon coming out of the ground is a big deal, and houses commonly have these little fan things in their basement to pump the radon out. Hopefully fallout will remain a small contributor to this, but kind of overall average background radiation exposure in the United States is about 3 millisieverts per year. So remember I said how a CT scan these days is around 10. So just to give a frame of reference, radiation exposure is higher in Denver. I always thought it was due to pure elevation and getting more cosmic radiation. I read the title of an article that was talking about some other causes, but I didn't have time to read it. Flying. Basically, if you make 3 dozen transatlantic flights a year, you're doubling your background radiation exposure. It's substantially higher if you're flying over the poles of the Earth. Similarly, if you work in the US Capitol, the granite and marble there has high levels of natural radiation, so that increases. So just to kind of try to help put things in perspective, which, a CT scan is a couple years worth of background radiation. A chest radiograph is a couple days worth of background radiation. And the risk theoretically, the risk of having a cancer caused by an imaging study is extremely small. It is hard to define that risk because, frankly, so many people get cancer. I mean, the prevalence of cancer in our country is high, not just uveal melanoma, I mean all types of cancer. So it's hard to kind of tease out what's from scans and what isn't. But again, this is kind of extrapolated from data and theoretical and that kind of thing. But people a lot smarter than I pretty much feel that once you hit age 35, the chance that appropriate medical imaging with radiation is going to cause an added cancer is almost zero. It does have a higher effect in young people, particularly kids. But once we reach that age of 35, yep, in many ways. Okay, so we talked about contrast being used for scans, and ultrasound contrast and MR contrast are totally different. CT contrast is iodine-based. I mean, hey, we need iodine to live. Your thyroid needs iodine to work, okay? So MR uses gadolinium, which is a metal, okay? The risk of an allergic type reaction to CT contrast is very low. With modern contrast agents, the risk of a severe reaction is probably on the order of 1 in 10,000 or less, 1 in 30,000, 1 in 50,000, that sort of thing. The risk of an allergic type of reaction to MR contrast is even substantially lower. Most reactions are minor, hives, itching. More serious reactions are shortness of breath. Potentially there is a very small chance of having a severe reaction which could require having a breathing tube placed. Nausea and vomiting are not allergic type reactions. They're very annoying side effects. Traditional teaching is that the iodinated contrast used in CT scans has a risk of affecting kidney function. Traditionally, that's been taught patients who are diabetic, patients who are older than 65, patients who already have compromised kidney function are at a higher risk. There have been several studies come out over the past few years that say, you know what, this might be a lot of dogma that isn't borne out by modern medical practice, and the risk of hurting the kidneys from X-ray contrast is probably a lot lower than we think it is. In patients who have compromised kidney, who are on dialysis or have borderline kidney function, they shouldn't get gadolinium for an MRI because they can get something called NSF, nephrogenic systemic fibrosis. It's a horrible disease. Basically, it very rarely occurs because those patients just don't get gadolinium anymore. That doesn't happen in people with normal kidney function. But as Kristen alluded to, the FDA is now looking at gadolinium-based contrast agents and retention of the gadolinium in the body, particularly the brain. And they did issue some warnings about this, but as they say, even though we now know it happens, no one has shown that it has any health effects or that it makes any difference. And in general, their conclusion is that the benefit of all approved agents continues to outweigh any potential risks. Basically, if you have something going on that you need the scan, you need to make sure the scan gets done properly, or why bother going through it, okay? This is getting into chemistry, which is well beyond me, but there are two classes of these gadolinium agents. There are linear bound and macrocyclic. We prefer use of the agent Eavist because it is much more sensitive at demonstrating very small liver metastases. Even though it is in the linear class, it's among the lower accumulators in the body because you give a lower dose of it, it gets excreted by the kidneys of liver, and just the way the compound is made, it's more stable than other agents. Venturing into the world of looking at images from a research to help guide research studies. This is a kind of simplified version, but I wanted to include this because you may hear some of these terms in the next hour, and I wanted to make sure you know what they mean. Okay. In looking at a scan after having some type of therapy, a complete response means the tumors went away. A partial response means they're at least 30% smaller. Progression means they grew by at least 20%. And stable is considered the whole area of, well, maybe they grew a little, maybe they shrank a little, but not that big a difference. Okay. Just to show a couple MRs of two different patients who I've seen over the past couple years. Again, this is the front, this is the back, this is the left, this is the right. This big gray thing is the liver. And these are what liver metastases look like on a scan performed with Eavist in a patient whose MRI was normal 6 months ago. And to discuss the importance of screening, but then also doing something about it. This is a patient who had a very small tumor in December. She was told to get a follow-up MRI in 3 months. 4.5 months later, it grew substantially. We saw her 2 or 3 weeks later, and her daughter was getting married. I didn't want to treat her a week before the daughter's wedding in case, heaven forbid, she had some complication or something like that. So she had an MRI, I think, on a day or two before the wedding and came for treatment the Monday after the wedding. But just look at the dramatic growth of this tumor in 6 months. Happy to take any questions.
Is there a way to know, or who would you ask if you're getting images, if you wanted to get an independent evaluation of whether you have a high quality MRI or not. You know, from an anecdotal, I know you said that there's variability. I've got my brother-in-law's brother in South Dakota had some back work done, and he had an MRI there, and then he went to a specialist in Florida. He said he can't believe the difference in the MRI images between what he got in South Dakota and what he was getting from these guys that do it all the time in Florida. He said it was like night and day, like a high-res versus extremely low-res sort of thing. So how do you know if the images you're getting are of a quality that they should be to pick up the kind of metastases that you might be looking for?
That's a very good question, which I need to think how to answer that. That's a very good question, which I need to think how to answer that appropriately. I didn't say diplomatically, I said appropriately. And part of it is, I guess the issue is having someone else who's treating you look at them and say, does this have the information I need or does it not? Okay, would be my first response.
So as an example,
I'm struggling to find a better answer for that question. I can't look personally at everyone's MRIs.
No.
But I mean, it is embarrassing. I mean, because you see work done by other people, and you know they're getting paid the same as Jefferson or University of Colorado to do the MRI, and if they're not taking the time to do it appropriately, and it's
well, I guess, and I can give you my particular example. It's a question that never occurred to me that I should be looking for a good MRI. I did wonder after hearing this story about after my brother-in-law explained the difference, and I said, I wonder how good mine are. And obviously, the one I had was good enough to pick up a tumor in the liver, but it went from locally imaged to my doctor out to my interventional radiologist, and ultimately read by you, and you guys talked. Okay. But I never thought to ask in that process, is this a good image? Is that a good question to ask in that process?
Well,
yeah, in this case, I mean, I had 3 doctors look at it, including you. I think Dr. Sato, probably 4. My local interventional radiologist, who's very good, and my oncologist. So.
I mean, I think if your local guy felt that it had the information he needed, that should be a reasonable vetting process. And I thought of something halfway through your question that I was going to add, and I already forgot it. I'm sorry.
So it's not just those of us with cancer.
No. It has to do with that being over 35 point. Oh, okay. Another total non sequitur, though, something I thought of on the plane coming out here and meant to add. Magnets for MRIs come in different strengths. Okay. The standard at most places is a 1.5 Tesla magnet. Tesla is a, not in my driveway. Tesla is a unit of measurement of magnetic strength. Please don't presume that a 3 Tesla magnet is going to be better for looking at your liver than a 1.5. Frankly, 1.5s are better. Okay, 3 Tesla magnets are good for certain other things. Again, out of my area of expertise, I think brains are better with a 3 Tesla. I'm not exactly sure on that. But don't think you have to have that for your liver, because actually it often induces some more artifact than what we need. And just one other comment I meant to make earlier about when we were discussing the fact that CT scans miss tumors, it does give one pause and make one wonder when research trials are done with this disease and they're only looking at CT scans, how much are they missing, and how accurately and adequately are they evaluating what they're trying to assess.